Good morning, all of you. And thank you, sir, for inviting me and giving me opportunity to present here on behalf of our department. Today, I'm going to share with all of you our experience of using radiofrequency ablative therapies to manage the patient's chronic pain. Well, radiofrequency was invented in 1950s by the Cosman, but it's found its way into pain medicine in 1970s because at that time it was felt that local anesthetics were giving only short lasting pain relief to patients who were suffering with chronic pain, and it was observed that using the radiofrequency ablation to the neural tissue that was giving long lasting pain relief to the patients. So all over the world, people or the started using radiofrequency ablative therapies in these patients. If we talk about our department, we got our radiofrequency machine first time in 2009. And since then, we have been using radiofrequency ablative therapies in patients with chronic pain. And of all the patients which we see in our pain clinic, about 10 to 15% of all the patients, they fit for undergoing these procedures. In the last span of 14 to 15 years, we have done more than 1,000 radiofrequency interventions. And for the last 6 to 7 years, we have been regularly following up the patients and documenting their outcomes regarding efficacy of these procedures. During our experience, the invasiveness of radiofrequency interventions, it ranged from a least invasive procedure like knee genicular nerve radiofrequency ablation, because genicular nerves are very superficial and they are easy to locate. And on the other hand, is a procedure like cervical cordotomy, which requires placement of radiofrequency needle into anterolateral spinothalamic tract. I still remember this patient. She was a diagnosed case of C lung with vertebral metastasis. And because of vertebral metastasis, she was having severe pain in her right lower limb. And after cervical cordotomy, we were able to provide good pain relief to this patient. Radiofrequency ablation is application of high frequency alternating current to the human tissue to produce thermocoagulation. And when it is applied to neural tissue, it inhibits nociceptive information going to the brain, hence giving pain relief to the patient. A radiofrequency machine has few necessary components. This is radiofrequency generator, which houses all the settings which we use during our procedures. Then a radiofrequency needle that is inserted into the patient, then the grounding pad. So this is how the circuit is completed by the body. And the radiofrequency lesioning or the thermal ablation is produced around the tip of radiofrequency needle. Now, when the electric current is high frequency or electric current is applied to the body tissues or the neural tissue, there is frictional oscillation of ions. And because of frictional oscillation of ions, there's a generation of heat. And this heat produces thermocoagulation. Now, because of his thermal injury, there is axonal injury. And if we grade this axonal injury, it is grade 3. What I mean by grade 3 is that epineurium and perineurium is still intact. In a matter of 1 to 6 weeks, there is Valerian degeneration of the nerve fibers or the axons. But in a time of 1 to 6 months, they grows back because the basal lamina of Schwann cells is still present there, and it brings about regeneration of those nerve fibers. So sometimes when these nerve fibers regrow back, there is return of patient's pain, sometimes at the same intensity, and majority of the time it is at the reduced intensity. Chiefly, there are two modes of radiofrequency ablation. One is thermal radiofrequency, and another is pulse radiofrequency. In thermal radiofrequency, of course, there is thermal damage to the nerve fibers. And in pulse radiofrequency, there is a generation of electromagnetic field around the needle tip. Now, this mode was invented in 1998. Now, as I've talked earlier, the lesion is produced around the radiofrequency needle and is prolate spheroid shape around the needle tip. And in pulse radiofrequency, there is no histological lesion. Because the application of electromagnetic field, it alters the functioning of neuronal membrane ion channels. And this alteration brings about analgesia to the patient. We use temperature of 60 to 80 degrees Celsius in thermal radiofrequency, and the temperature reaches up to 42 degrees Celsius in pulse radiofrequency. So the nerve functioning become dysfunctional above a temperature of 45 degrees Celsius. So it is quite safe to say that at 40 degrees Celsius, there is no thermal injury to the nerve fibers. In thermal radiofrequency, the energy applied is in continuous mode. But in pulse radiofrequency, it is applied in pulses. And because of application of electrical energy in pulses, the heat gets dissipated. So that's why the tissue temperature does not rise above 42 degrees Celsius. The duration used for thermal radiofrequency is 60 to 120 seconds, and for pulse radiofrequency, it is 120 to 480 seconds. The thermal lesion in thermal radiofrequency, it is produced around the needle tip, and it is mostly along the shaft of the needle tip. And it is around 2 to 4 mm from the needle location. So that's why the needle has to be precisely located in vicinity of the nerve fiber to have adequate lesioning. This another mode, which is you can say a iteration of thermal mode, and this mode is known as cooled. But the name cooled is counterintuitive. In reality, the thermal lesion size is larger in cooled radiofrequency. In cooled radiofrequency, there's a separate channel inside the needle in which water circulates. And this water takes away the heat from the tissue. So that's why the lesion size is bigger in cooled radiofrequency. Here you can compare the lesion sizes. This is the lesion size of cooled radiofrequency, and this is the lesion size of thermal radiofrequency. So the lesion size is here much larger. Because when the water takes away heat, the tissue charring is not there. So the electric current, it passes at a far away distance in the tissue. Now, in our department, in our OPD, we see a lot of patients of chronic pain, and we get patients directly and also a referral from almost every department of the hospital. We get chiefly referral from neurosurgery, neurology, gastrosurgery, gastroenterology, immunology, hematology, urology, to name a few. And they refer our patient for the management of patients of chronic pain. We have used radiofrequency ablation in conditions of joint pain, in which we cover knee osteoarthritis, frozen shoulder, and hip osteoarthritis. In facial pain, we treat patients with trigeminal atypical facial pain, supraorbital neuralgia, and glossopharyngeal neuralgia. Low back patients, they constitute majority of our patients. And radiofrequency ablative therapies can be utilized in different causes of low back pain. To name a few, lumbar facial joint dysfunction, it is responsible in majority of the cases. In abdominal pain, we treat patients of chronic pancreatitis and ilioinguinal or iliohypogastric neuralgia. And for neck pain, the facial joint dysfunction, and of course, some of the patients with occipital headaches. Now, how do we decide about doing these procedures? Now, whenever a patient comes to us, we try to manage these patients on conservative lines. And once this conservative therapy fails, at least for 3 to 6 months, then we think about doing these procedures in these patients. Now, these procedures are daycare procedures. And we do these procedures in a dedicated pain OT. Before doing these procedures, these patients has to undergo a pre-anesthetic evaluation. And then these patients are admitted on a daycare basis. And usually, most of the patients, they get discharged by the evening. And after we decide that we have to do radiofrequency interventions in these patients, we first subject these patients to diagnostic block with local anesthetics. Now, these local anesthetics, this serves two purposes. First, it confirms our diagnosis. And second, it gives us an idea that how the patient would fare after the therapy. And after, in the diagnostic blocks, if the patient gets 50 to 75% pain relief, then we do radiofrequency ablative therapy in these patients. This is how a typical radiofrequency procedure is done. First, we locate our target under the fluoroscopic guidance or ultrasound guidance. Then local anesthetic is injected. Then radiofrequency needle is placed under the fluoroscopic guidance. Then we confirm the location of the needle with sensory and motor stimulation. This is a case of medial branch block. So here you can see multifidus contraction of the muscle. So it confirms the location of medial branch. And thereafter, we do thermal radiofrequency ablation. Contraindications are if the patient refuses to undergo these procedures, if the presence of coagulopathy and pregnancy and pacemakers are relative contraindications for these procedures. So this is our experience for the last 7 years, and mostly we have treated patients of low back pain and joint pain. We get maximum experience of trigeminal neuralgia and facial pain, then facial joint dysfunction, in joint pain, knee osteoarthritis cases, and we have done few cases of chronic pancreatitis, post-traumatic, upper limb CRPS, and neck pain. So, approximately 291 patients, we have done radiofrequency therapy in the last 7 years, which we have the full follow-up data. We document following outcome measures during follow-up of our patients. First is numerical rating scale, the score from the more the score, the higher the intensity of the pain. Then multi-dimensional pain assessment scores, osseous disability index in low back patients, and higher the score, higher the disability. Then Oxford knee score, mainly in knee joint pain. Then efficacy, the number of patients who get more than 50% pain reduction after the therapy. Then analgesic dose reduction, the number of patients who gets more than 50% reduction in medication doses. Then we also document the complication rate in our procedures. I'm going to share our experience of doing radiofrequency ablation in these chronic pain condition. First, I would like to start with facial pain. In facial pain, we have treated these conditions, and among these, trigeminal neuralgia predominates. We have done 40 cases of trigeminal neuralgia, followed by supraorbital neuralgia. These interventions are indicated in those patients who are having severe electric shock-like pain along the distribution of trigeminal nerve, but they are not responding to conservative therapy. This is how we do it. The patient has to lie supine on the operating table, and under the fluoroscopic guidance, we locate the foramen ovale. Then we place our RF needle into foramen ovale. Then we confirm the location of radiofrequency needle in multiple views of fluoroscopy. After confirmation of radiofrequency needle, we do radiofrequency lesioning. Usually 3 to 4 lesions are given for Caesarean ganglion. And the temperature range used for Caesarean ganglion RF ablation is 60 to 70 degrees Celsius. Here you can see contraction of masseter muscle on motor stimulation.
1, 2.
This is we do to exactly localize the nerve. We have observed a significant reduction in pain post-procedure, right from 1 week after the procedure to up to 12 months. We followed our patients up to 12 months, and we have also observed a dose reduction in the gamma-visibine of the patients. However, we noted few short-lasting side effects of these procedures. But none of the patients at 12 months were having any adverse effect or complications. This is our work compared to the literature. You can see that our work, our results are quite comparable with the literature. And you can see that here, these authors, they have reported that at the 12 months, 82% of their patients were without medication. It may be that they have used higher temperature for RF ablation in their patients. The next entity is atypical facial pain. The facial pain, which is dull aching, poorly localized by following any dental or surgical procedures. We do sphenopalatine ganglion RF ablation in these patients, and we place our needle into pterygopalatine fissure to locate the sphenopalatine ganglion. And this procedure is done under fluoroscope. This is how it is done. We place our needle into pterygopalatine fissure in close to sphenopalatine ganglion, and we confirm it in multiple views, and thereafter we do our radiofrequency ablation at 80 degrees Celsius for at least 90 seconds. This is our data regarding these patients, and all of these patients, you can see that at the end of 12 months, there were approximately 5 to 6 decrease, there was 5 to 6 point decrease in NRS scores in these patients. And we noted facial paresthesia at 1 month in 3 cases, and that was also transient. Our results are quite comparable with the literature. Now, Seller et al. Reported 100% efficacy at 12 months because they have subjected the patients to multiple interventions. And another entity is supraorbital and supratrochlear neuralgia, the patients who are having sharp electric shock-like pain in the frontal head. So we target supraorbital and supratrochlear nerve in these patients who are not adequately managed with conservative therapy. This is the placement of radiofrequency needle. This procedure we do under ultrasound guidance. Here we utilize pulse radiofrequency mode. And we found satisfactory analgesia in these patients after subjecting patients to a single session of pulse radiofrequency. This is our result in comparison to the literature. Now, these authors, they have higher efficacy, slightly higher efficacy, at the expense of higher incidence of facial numbness because they have utilized thermal radiofrequency coagulation as compared to our results, in which we have used pulse radiofrequency. Another entity is glossopharyngeal neuralgia, the patients who are having severe pain in the back of the throat or tongue or the ear. And here we locate the glossopharyngeal nerve under ultrasound guidance and then do pulse radiofrequency lesioning in these patients. Here, the glossopharyngeal nerve is located with the help of styloid process under ultrasound guidance. And after this, we do PRF lesioning in these patients. Our experience is limited in this entity. We have done only 3 cases, but only in all the 3 cases, we have found significant relief in pain. And we were able to dose the analgesia also. And there was a transient side effect. Our results are quite comparable, although our experience is limited. Then another chronic pain condition we treat is joint pain. Chiefly, we use it for knee osteoarthritis and adhesive patients of adhesive capsulitis. We have done 60 cases in knee osteoarthritis and 30 cases of adhesive capsulitis. Now, there are plethora of genicular nerves around the knee joint, which we target to relieve the patient's pain of knee osteoarthritis. So, the radiofrequency needles are placed in vicinity of genicular nerves. And after confirming their location, we do thermal radiofrequency ablation. This sometimes we have to give 2 to 3 lesioning at the location of genicular nerves. In our experience, we have observed post-procedure reduction in NRS scores as well as OKS scores. And after it was maintained till 6 months, but at 12 months, there was slight increase in NRS scores and OKS scores. But still, it was less than pre-procedure values. Approximately 40% of the patients were able to reduce their analgesia. And we encountered the most cumbersome side effect in these patients was needle entry pain, because the needle genicular nerve lies over the periosteum. So, and we have to walk our needle over the periosteum. So that's why there is such a quite number of patients, they complain of needle entry side pain. This is our comparison with the literature. Now, these authors, they have reported higher efficacy in their procedures because they have defined their higher efficacy by reduction in 2 point in NRS scale. But we have defined our efficacy as more than 50% pain relief. Another condition is shoulder pain, and we target suprascapular nerve in these patients. The suprascapular nerve, it supplies about 70% of the shoulder joints. That's why we target suprascapular nerve. And we use pulse radiofrequency mode in this condition. And we use ultrasound guidance. First, we localize the suprascapular notch, which houses the suprascapular nerve. And after confirming its location, we do PRF lesioning. We have a follow-up 6 months in these patients, and we have found moderate relief in pain in these patient population. Our results are similar to what other authors have reported in their studies. The majority of our patients are of low back pain. Now, low back pain has a multitude of causes. A number of components are there which can be responsible for low back pain. Facet joint dysfunction constitute 20 to 40% cases of low back pain. Then the pain due to degenerated disc, it might be age-related or trauma-related. Patients with prolapsed intervertebral disc, SI joint is responsible for 20% of the patients with low back pain. Majority of the patients have myofascial pain as a co-component. The cranial nerve entrapment might be responsible for low back pain. We have used our radiofrequency ablation to treat these entities. The foremost is lumbar facet joint dysfunction. We have done foremost cases of facet joint followed by superior cranial nerve entrapment. Now, each facet joints are supplied by medial branches of dorsal ramus of lumbar nerves. And these nerves are located at the junction of superior articular process and the transverse process. We locate these nerves under the fluoroscope, and then we do thermal radiofrequency ablation. In these cases, in this case series, we have done cool radiofrequency ablation. Here you can see contraction of multifidus muscle because the medial branch supplies the multifidus muscle. Right after doing the procedure, the patient, they reported adequate pain relief, and this pain relief was maintained for 12 months. The trend for ODI score also followed the trend of NRS scores. We reported increased back pain in 10 patients because cool radiofrequency needles are of large gauge, 70s gauge. So they produces more needle entry site pain. Both of these works are by Cornick et al. And our results are better because at 6 months, and it is quite comparable at 12 months. The other entity is superior culinar nerve entrapment. Now, these superior culinar nerves, they get entrapped in thoracolumbar fascia above the iliac crest. So we target these nerves above the iliac crest. We locate these nerves and then we do thermal radiofrequency ablation. In these patients, we observed a drop in 5 point in NRS scores at the end of 6 months. And also there was significant reduction in ODI scores. And we did not observe any adverse effect in these patients. We also, our results are quite comparable with other authors reported in the literature. Then another is sacroiliac joint dysfunction. For this, we do radiofrequency ablation of lateral branches of dorsal MS of S1, S2, and S3, and L4 and L5. For this, the needle has to be placed at 3 o'clock position of the sacral foraminus. And after locating that, in multiple views and confirming their location, we do thermal radiofrequency lesioning. This is our data regarding patient outcome. And we noted 50% reduction at 1 month, and this pain relief maintained for 12 months. And we didn't experience any major side effects in these procedures. Our results are as good as what is reported in the literature. Then for abdominal pain, we have treated patients with chronic pancreatitis, and we have targeted thoracic splanchnic nerve in these patients. Now, the abdominal visceral sensations are carried out by splanchnic nerves, and these splanchnic nerves, they lies at the level of T10 and T12 vertebrae. And so we target these nerves under fluoroscopic guidance. And in our experience, the patients of our therapy, they reported adequate and satisfactory analgesia after this procedure. We have experienced a case of intercostal neuralgia in one of our patients, and later on it was found that it was because of a faulty radiofrequency needle. There was break in the Teflon covering of the needle, and because of that, patient had intercostal neuralgia. We published this as a case report in a high impact pain medicine journal. Our results are as good as what is reported in the literature. Then another entity is coccydynia. The coccydynia patients, they get pain whenever this sits on a hard surface. For this, we target ganglion impar, and ganglion impar lies in front of the coccyx. We go to the sacrococcygeal space and then do our radiofrequency ablation under fluoroscopic guidance. This is our outcome, and we were able to give adequate analgesia, adequate pain relief to these patients. Then another is transdiscal biopuplasty, which we have done for patients of degenerative disc disease. The patients who have pain because of degeneration of disc. For this, the two cooled radiofrequency needle, they have to be placed in the posterolateral aspect of the intervertebral disc. And after that, the bipolar lesion is created inside the disc. It is done by cooled radiofrequency method. We have a very limited experience of this, and we did not have quite satisfactory result with this entity. One patient had a follow-up, we have follow-up of only 3 months, another patient up to 12 months. Then we got a lot of patients of CRPS in our pain clinic. This is a case of post-traumatic upper limb CRPS. As you can see, this hand is having CRPS symptoms. For this, we have done T2, T3 sympathetic ganglion, RF ablation. And this is the location of T2 and T3 sympathetic ganglion. And we place our needle under fluoroscopic guidance. Then we do RF ablation at 80 degrees Celsius for 60 to 90 seconds. We have observed at least 50% pain relief at the end of 6 months, and 90% of the patients were able to reduce their analgesic dose. So, in a nutshell, radiofrequency ablation as a viable option in those patients who failed conservative therapy at least 3 to 6 months, because we have observed these procedures have a propensity to give reduction in the analgesia uses along with reduction in their pain. It's a minimally invasive day care procedure as compared to surgical options, and they provide excellent to good pain relief with minimal side effects, and they are repeatable. If the patients gets their pain back after some time, they can be repeated. There is a good evidence for trigeminal RF ablation and facet medial branch radiofrequency ablation in the literature, and there is moderate evidence for knee gellular radiofrequency ablation. And for others, the evidence is evolving. Thank you.